Hey everybody, it's Elge back for Simple Lines Anatomy, and this is part 2 of our two-part series where one of our followers asked us to do an anatomic assessment on why they're having some pain or what our thoughts are on that based on their position and their structures. So I have to start, of course, with the simple fact that I am not a doctor. I am not giving medical advice, nor a real medical diagnosis, and this is for educational and artistic purposes only. Frankly, I don't even think I'm that smart, so do what you will with all this. I also have to say, because I'm using actual pictures of this person, I'm doing this at a distance. I've never met them. I can only use images, and I have some videos. I won't be showing those, but I have some videos that I've grabbed images from. I can't do any direct palpation, so at best, we're getting educated guesses. I think they're not bad, but they're educated guesses. And I'm going to be wrong in some parts, straight up wrong, and you may disagree with me on some parts, and I'm okay with that. I'm willing to live with that. I expect that. But I think a lot of the times I'll be right, and that's important too. Another thing I have to mention, I'm going to be focusing on the position of things. I'm going to focus on where one bone is, one joint is relative to the others, and I'm gonna not spend a lot of time naming the soft tissues in between. There's so many, and we would get bogged down in an encyclopedia that way. So we're going to avoid that. Just understand, in general, if it's bent forward, short in the front, long in the back. If it's bent left, it's short on the left, long on the right. And usually, not always, but usually we could say the short side is the one actively holding the position, whether it's through active contraction or through shortened fibrosed tissues. And the longer side, the stretched out side, that's the one that hurts. Usually, not always, usually. If you can just look at the tissue orientations, the way things are fibered, you can pretty much figure all of this out, where to work, where you'd want to work in these cases. So that's just... there's our big set of disclaimers. On to the real stuff. Let's get rid of all this. So, hopefully, you right away notice some differences in these pictures. Right away. So, we're going to take a look at how the neck lateralizes, side shifts. In our previous video, and do take a look at that if you already haven't, we explained how the neck can cause just a whole bunch of potential pains in the body because of the nervous system, because of the brachial plexus, really because of the wiring in that system. So I'm going to say right now, I think that neck is pretty stuck in a certain area. Pretty stuck. Period. That's how I wrote it. And I'm going to say, just based on this, it's right about here. And that's at, see, 5, 6, 7 ish area. That's more the upper end of the brachial plexus. So there would be, of course, cervical vertebrae. There's your SPs right there, and they're the ones that are kind of wedged, all jammed together. So just take a sec to notice the difference between these two positions here. One, we have a relatively straight, smooth curve, and in this other one, let's just get rid of this. So let me grab that up, move it out of the way for a sec. Other one here, we have more of a side shift going on. Notice how this is not so straight in this region. So look at the curve on that one versus the curve on this one. Hopefully you notice a difference pretty early on. So we know there's a difference in the neck. Both of these are side bending pictures. The top ones are rotational pictures. And this means that when he's trying to bend his head, he's really bending his whole body to the side, trying to bend his head to one side or the other, we get a change, a difference in the mobility of these areas, and it's cutting out right about this area right there. That's something that is unmoving. It's not adding to the position. And I'm going to say, personally, I think this is a translation motion that has happened here. I think it's stuck, in fact, in the translation here. For those of you who don't know, translation is what you call a planar motion. And so let's say we have a few vertebrae. I'm just drawing them straight like this. A translation would be where one or more, could be lots of them, one is gone straight in a planar motion to the side. It's gone, in this case, because it's going sideways, that would be the coronal or frontal plane. So it's gone straight to the side. Cervical spine actually does this relatively well. So this is a curve, goes too far here, comes back around that way. That's what I'm seeing. So the translation is here towards the right. It's being pushed towards the right in that, 5, 6, 7 area. Now, interestingly, because it is pushed towards the right, we can use this one here. It means it does actually bend. This is weird, but it would bend towards the left. I know that's confusing, but just understand it approximates. It comes together on this side easier because of that. So because those facet joints on that side get closer together. Now what should happen as a result of this is actually we get better side bending to the left. So there you go. And we actually, because the cervical spine has a type 2 Fryette, it should also rotate to the left. What do you notice about these pictures? Does it rotate to the left better? I should think so. We've got more face showing up in this picture as opposed to more face showing up in this picture. So here he's turning his head to the right. Can't get it nearly as far as when he turns his head to the left. So that's confirming a few points. That's using multiple motions to kind of confirm the same thing. Again, I could be totally wrong in this. I don't think I am here, but we seem to have more than one proof. Now, if this is the case, it has to be that the shortened and tightened tissues would be more on the right, the scalenes, I'm going to say. We mentioned the scalenes in the last video. They'd be coming off like this. There would be our TVPs, transverse processes, on the sides of the neck that are about there. Let's say, because they got that little double thing there. 2 tubercles, and then there's the actual spinous processes like that. Ugh, it's horrible. Hold on. There's the spinous process. We'll say it like that. There we go. And the scalenes are the ones that are just coming off the sides here. These are the short, thickened one. It's holding it, pulling it into this kind of a bend. Hold on, let me do that again. This kind of a translation. It's short on that right side. It's holding it towards the right. In that lower area though, not the top area. So this is important because again, we spent some time in the first video. Give it a chance to watch it. Give it a watch if you haven't already. Now what this means is it's fixed or unmoving. It's stopped moving down below in this area. But that would have to mean that above it, and usually this happens, it's hypermobile. It's in fact excessively mobile above it. And both these things are very important because if we have a lot more motion happening here and not so much motion happening down here, typically that means something is overworking. Again, I'm going to go to the scalenes. We could go SCM, that would be around there. We can go to the trapezius as well, in and around there. But I'm going to say the scalenes are going to be the most directly impacted by that because certainly when we rotate, if we have the capacity, we're being pulled hard on this side. We're pulling very, very hard. And even though, in the last video I talked about this, even though on the other side it's short and contracted or contractured, whatever you want to call that, that will impact the pressure in and around that brachial plexus. Well, lots of strain, lots of pulling apart, too much separation of those tissues can also impact that brachial plexus, can also impact those nerves that travel out and down the arm. They actually come out between the anterior and middle scalenes, and so that's important. Either side, it's going to be important. Either side can pose a problem to that brachial plexus. So we've got a bit of a case just based on this. I know this is simple. This is just seems like it's nothing. Like if you didn't know any better and you had no training whatsoever and had no anatomy training, you would probably just go, oh, well, they can't turn their head. What's the big deal? Well, there's more stuff in there than that. So I think we've got a combination, in fact, of both strain, pulling too hard on the tissues, irritating, and then a thickening of the tissues, a fibrosis of those same tissues on the opposite side. And that's going to affect us down the line. Now, because of the fact that this area in here, because of the fact that it looks to be unmoving, again, a guess, but I think a decent guess, because this area in here, that 5, 6, 7 area, looks to be unmoving. I would say it's very rigid. So it's got a lot of thickened tissue in and around. It's got a lot of stuff that's holding in place. I'm going to say it would be wise to move this slowly. If you were going to go after this with some kind of myofascial release or some kind of muscular mobilization, I think a wise choice would be to approach it slowly. I don't think this is the type of thing that should be just jumped on. That would be probably a bad idea. And I do believe this has been there quite a while, minimum a year, based on what this person has explained to us. So not something that we just want to go try and hit with a rock. Yeah, just, I think. Anyways, just an opinion. All right, now, I need to mention one more thing I feel is important. It helps us time and sequence the issue. So he had some previous work with the physio right after this this problem came up. The neck pain and the pain down the arm and the pain in the pectoral area. There was some doctors seen, which is great, and there were some referrals to the physio, also awesome. And he noticed that right away he had some rounding in the shoulder. So basically the shoulder was coming forward, and it was more on the left side. I've drawn it on the right, but the shoulders, they round this way. They were doing slouching down. And so he had some pretty extensive work. I don't have any images of that time, just because didn't take any. And I just want to say clearly some good work was done to align those shoulders, because he's capable of moving that shoulder around. Wasn't able to before that physio work, according to his retelling of the story. So some really good work was done there. However, the fascial issues or the neck fascial shortness remained, and this means it was there first, underlined first. That's an important thing to sequence this. If the shoulders can be reduced, if they can be made to be better, if they can be taken away unrounded, then that usually means, and the neck problem remains, that usually means the neck problem was there first. It has had the most time to thicken, to fibrose, and become immobilized. So you can guess which order it was. And it's really important that the shoulders got fixed, but it didn't fix the neck. So you can kind of guess that the shoulders didn't cause the neck. It was probably the other way around. I just wanted to say that because I felt that was really relevant. And we're going to build our way down. We're essentially going to build our way down because we have a case, again explained in the last video, that we can have expressions all the way down to the pelvis through the lats, because those nerves in the neck, the thoracodorsal, for instance, which is a really important nerve, but that actually travels all the way down to innervate, give nervous impulses to the latissimus dorsi, and can change the position of pelvis. So let's keep on going, working our way down the whole system. So where are we now? Pull off some of that. Okay, let's look at this neck in the side view now. Hopefully you can see. I'm going to point it out, but hopefully you can see right away that something's going on here. So this curvature, don't love the look of that. That's not great. There should be a little bit more of an extension curve, and it should be smoother. We're looking a bit flat through here. So we mentioned the translation, pushing that way, but also notice that we've got kind of a general flexion through this area. Let me just bump up the size of my brush there. So we've got kind of a general flexion. I'm just going to write that a little bit. Coming through there. So this part looks pushed back. Looks like it was pushed that way a little bit. So I'm saying flexion, and that flexion curve goes through there. So linking up the two areas. So we've definitely got the C5 involved. I'd say all the way down to at least T4. Could be a little bit lower, but C5 to T4. And this will tie in those neck problems, that neck problem from there all the way into the thorax. It will combine those into a unit. If it's thickened and fibrosed in this region, if it's all wadded up, probably goes all the way down into here. And again, I'm going to try and justify this to make some sense of it. So it's not just the neck, it starts to go lower, and we're going to work our way well down. We should be able to justify everything we've got going on just by functional anatomy. So understand that when we have shortened scalenes, or scalenes that are contractured or contracting, and I'm assuming both are happening. The scalenes are running in this orientation, and so that means they are capable of pulling up. So even though they're to the neck, they're actually going to be pulling up on the rib. They are breathing muscles in a way. They can move the neck to the side, but if the neck is unmoving, that means the neck is the more, or sorry, the ribs are the more pulled upon part. The neck is fixed in space. So the scalenes tend to pull it up, and there's quite a few branches, so we actually get a good pull on this rib here. So the rib one, we'll just talk about rib one. We'll draw just rib one in for sake of ease. Comes around that way, like so. Comes around this way, and the scalene muscles attach to it, and then it goes on and attaches to the sternum. So when those muscles contract, when they shorten, they lift that rib up, and they'll in fact lift rib 2 up as well. I'm not going to draw the attachment of that one, but they lift rib 2 up as well. And so that has an effect on the thorax, because the ribs 1 and 2 attach to vertebrae 1 and 2. Now, something often interesting happens when we have lifting of the ribs chronically by the scalenes. This is what I've seen, but a scalene pull, so let's say that's T1, that's T2, and they've got their spinous processes sticking off of it, and then ribs 1 and 2 just kind of come off like that. So that'd be rib 1 there, and that would be rib 2 here, and I'm not going to draw them the whole way around. But when they come up, when they tend to be yanked up by those scalene muscles, it also, they end up about here, kind of flat. It ends up dragging the vertebrae anterior, so it's starting to drop them forward. And when one vertebra goes anterior, when it does this, and it will happen to a number of them, in fact, it won't just be 1 and 2, it may go as low as 3, may go as low as 4. We can call this a flexion curve. So this starts to justify this rounding that we've got through here, that's starting to unify the neck with the upper thoracic area. So these things tend to go together, but it's more than that. So as we flex this, again, let me just flip it so it's like this. We've just exaggerated. As we've done this, we also bring the head forward, and so now our center of gravity is also forward. The head and the neck are forward, so the center of gravity has come forward just a bit. It's not a ton, and that's okay. It's not a ton, but it's enough to cause some problems. It's also enough to cause a need, once we drift that head forward, anterior as a center of gravity, to collapse the rib cage. The rib cage tends to round down. It has to round down because we've got this going on. But it also requires some flexions occurring in the rest of the spine. If we drop the head forward, something has to fold along with it. And for us, and we'll explain this later, it's the thoracic and the lumbar spine. This has to happen. If it didn't happen, you'd be looking at the ground all the time. You know, the eyes would just be cast down exactly like so in this picture. He's leaned forward. We asked for that on purpose. So for balance purposes, you must come forward. So this is dropping through the rib cage, through the spine. So it's starting to go from the neck, through the upper ribs, into the thorax, and now we're going to bring it further out into that rib cage. So the lower ribs, I'm going to say, are flared out on the right side. So we've gone from the top of the rib cage to the lower rib cage. We're saying there's a problem up here, and it goes all the way down to here. And now the follower, person who contacted us, told us this as well. We can back this up symptomologically and mechanically. You should always be able to do both if you want to be successful. So look at this picture. He's in this picture. He's going back on the right side, but he's side bending to the left. So this is the left arm here, just to be clear. This is the right, and he's bent to that left side, and he's bringing this arm back, this right arm back in rotation, backwards in a circle. And now notice this actually looks somewhat normal. The movement itself is meant to exaggerate. Again, I could not physically palpate anything. I couldn't actually feel anything, so I had to find ways, I had to create motions for this person to do to exaggerate certain body mechanics. And we did various iterations on this, more flexion, less flexion, that kind of thing, just so I could get a clear enough picture. And so this is what I was able, this is the one that showed it the best, though I had others. So notice not too much on this side, smooth curves here. But if we look at this picture where now he's bent to the right side, so he's gone this way, bending into it, and he's bringing this arm back in a circle, which is lengthening this side of the thorax. I think I forgot to mention that, but it's lengthening this side of the thorax when he really brings that arm back. You start to notice there's a bit of a weird shape running through the rib cage here, and it's even more noticeable when we're really bent to the side. So notice the kind of bulkiness is sticking out of the ribs here, and the fold we're getting. Whereas we didn't quite see that on the other side. We didn't see that here. And again, in the full video, it didn't show up in the same way. So we know we've got something going on with this right side of the rib cage. We've got something going on that's distorting that. Now this area here, this area that's popping up, this is cartilage. We're at the lower end of the rib cage. The xiphoid process is right about there. Let me do that a little different. There we go. Xiphoid process is right about there. It'll ruin my color for cartilage. I can't use up that blue. There we go. Now we can use blue. There's the cartilage right there. And it's gone and it's kind of twisted up. So there's like rib 10 and 11. Oh, sorry. 10 and 9. Basic anatomy. Okay, so there's 10 and 9 and 8 and 7 is where it actually physically attaches all together. And these are all one big chunk of cartilage in here, and this is it's very hard to really torque this up. It would be more bony out to about here. This is actually pretty hard to torque up. Cartilage is very resistant to bending until it bends, and then it gets stuck there. And it's difficult to do. So the fact that this has gone into, well, what I would call an outflare, that's what I'm just calling it. I've never heard anyone else call that, but it's kind of flared outward, as if it's come up here and inward, as if it's been pushed in on these lower ribs. This is a very palpable thing, and I've seen it in many different people. And so it's been quite torqued up. Cartilage, heavily resistant to this, but once it gets there, it's very hard to get it out. So we know that it's been there for a while. We know it's been there for months, if not years. And so this is something that has to be gradually worked out. And it's also showing what's going on more in the thorax as well, because again, this is to exaggerate thoracic motion. So we know it's stuck. We know something's going on in the back, because the ribs, and I'm going to say, because I know in advance too, but I'm going to say it's indicating also a right side bend in the thorax, which we'll show right now. So there's another view. So in this case, he's bending to the left. There's left. He's bending to the left. What do we notice about here? So bends to the left, it stays relatively straight. So look how there's a little bit of a bend up here, but not so much here. Look at those erectors too on either side. We'll make mention of that later. But it stays relatively straight when he tries to bend to the left. However, when we side bend to the right, since the right side, notice how there's a bit more of a curve. This darkened area through here is indicating that it's bending to the right. So it won't bend to the left. It doesn't go along when we try to bend it to the left, but it will go to the right, so we'd call it side bend right. And definitely this seems to be happening if we start to chunk this out. This area through here, this ain't moving, and that's about 7, 8, 9, 10. That matches up really nicely with what we were talking about. So this is, yeah, about, if that's the tip of the scapula, we'd say 7s, give or take. I'd say that's about 7, and then 8, 9, 10, 11. Anyways, you get the idea. That's where it's happening. Thankfully, that does match up with the ribs. So again, we looked at the ribs, just going back to that. I'm just going to pop that up. We looked at those lower ribs, and because we're seeing the xiphoid, because we're seeing the cartilage attachment here, we know it's in that 7, 8, 9, 10 area, and that also matches up with what we're seeing in the side bending test. So we saw the ribs being a little bit torqued up. Ribs go all the way around, so they come from the front to the back in those C shapes, and they're not that big. I drew them way too big. There we go. They're in C shapes like that, and so we know that they have to be matching up. If the vertebra, which is on the back here, if the vertebra are what the ribs attach to, and the ribs are distorted in any way, they should as well distort the vertebra. They go hand in hand. They go rib and vertebra. It's the best I can do. Anyways, as you press in, so as we get this fold here, again, he's going to the right side. As we get the fold, just going back to that, there we go. As we get this fold dropping to the right side, you can see that happening. In fact, it's probably happening a little bit excessively. We're starting to see some maybe laxity form. You're going to see the most of it in the lumbar spine, which we'll bring up in a bit. But that's really important. So it's folding really well to that one side, not so much to the other. And not only that, this is a point of flexion. So going back to an older picture, there we go. There's a point of flexion here too. So if you can see this, we talked about the flexion up here. Well, we can also say there's probably a flexion down here in that same area, in that same region, which is a big deal because we're, again, trying to compensate for an anterior center of gravity, this forwardness of the head, and these seem to be the two major points so far, making sense, making this into a bigger descending pattern, all of which are important, every single part of it. Okay, big part here, let me clear that out. So, lumbar flexion. Going back, let me first look at the erectors. I'm jumping the gun here. Let's look at these erectors again. Notice there's some real thickness on either side, some real tension here. This is indicating they're having to work extra hard. And even though these are extensor muscles, this is where it gets you. Even though these are extensor muscles, so let's say we are bending forward. We're bending forward like so, and I wanted to right myself. I wanted to straighten myself out. I would contract these posterior muscles here. I would contract these erector muscles as they pull down and they bring you into a straight up position. Spinal erector muscles, erector spinae. Now, you would assume that if we had very, very toned erector muscles, if we had muscles that were firing too hard, you would assume it'd be an extension, but this is not always the case. In fact, you may find in people with dysfunctional positions that the muscles are firing so hard because they can't get into the position that the muscle wants them to. Just like a muscle spasm, the muscle is trying to bring something back to the middle, but it's not capable of doing that. So what ends up happening is it fires excessively. So these erectors look so big, not because it's extended, but in fact, because it is very, very flexed. If you don't know this, this is an extreme lumbar curve. This is too much. Like, this is way too much. You can't have this kind of a curve normally. You really don't want this kind of a curve, in fact. And it's showing what the real problem is here in this region is that it's flexed too far, as if it was kind of being pushed back like so. And again, the erectors are showing, they are trying, basically showing that they have tried to pull it back. They've tried to pull it so it pushes that lumbar spine into extension, but it ain't working. It's not working at all. And so they're overtoned because they're failing. Okay. Theory. Don't know this for sure. We have, again, a few points, but we're thinking the sacrum is pretty stuck, and we're thinking it's stuck posterior. So we're thinking the sacrum is doing what we call counternutation. That's what some people call it, but it's just the base, which is the top part, unfortunately. The base of the spinal column sits on the sacrum, so let's say that's about L5. We're going to say we think it is posterior. Now, we had some video of it, and we basically had this person flex forward and turn left to right. As they flex forward more and more, the pushed backness of the sacrum didn't change at all. What should happen is they go into a flexion, and the sacrum gradually comes more and more back. It shows more prominently, but it stayed basically exactly the same the whole time. So we're going to say the sacrum is caught in a posterior position. There's a way you can get the same effect from the opposite, the sacrum caught forward, but we're just going to say it's caught posterior, and it's caught rigidly posterior, like it is stuck, man, and that's a big deal. So it's posterior or counter-nutated. Either of those words are fine, and this has meant to us, or we believe what has happened is it has caused the lumbar spine to have to compensate by flexing a lot more than it would normally do. So it is hyperextended into flexion. That's our guess. And because of that, the ligaments that normally run along these structures, there's like supraspinous we're drawing here, or there's the ligamentum flavum, which is actually a very elastic ligament, which should be present in most people through here. We're saying that they've been separated like so. They've been spread apart so much that they've actually lost some of their integrity in this case. And again, the body wants to neutralize that. It wants to keep it normal. So what it's going to do is fire muscles excessively hard. It's going to fire those erector spinae in some kind of attempt, a failed attempt, to get those vertebrae back into place, because it wants to maintain the lumbar curve, but it is not doing that. So the lumbar spine is now failed, essentially. This is another point of flexion, and it maintains everything above it, because if this area is pushed back, if it's flexed, then other areas have to go into both flexion and extension all around it just to compensate. So this will maintain the other stuff above it. With that, though, we could say a few more things, because there's always more to the story. So that sacrum, we feel, the fact that it's caught backwards, counter-nutated, means that its bottom end at least is short, if not pulling forward, on the tip or coccyx area, coccyx ILA area, inferior lateral angles. And what muscle would be there is actually the pelvic diaphragm. So we feel like that's probably short and fibrosed, and it's been that way a while. Now, he mentioned a procedure that he had. He mentioned a certain procedure, and we won't bother naming it, not relevant, and that he believes he felt a lot of this happened at around the same time. So that's an awful drawing of the pelvis. There we go. There, okay, that's a little better. Awful drawing of the pelvis, and the pelvic diaphragm essentially has a few different bands of muscular sling-like tissue that pull forward relative to the coccyx towards the pubic symphysis, and so this is the thing that could hold it in this position. He mentioned he had a pelvic related procedure, and we don't think that caused it, but it might have irritated something that was already offset, that was already wrong, and it exacerbated it. It probably would have happened regardless of having the procedure or not, but it just showed up more so because of the stress of the situation and the environment. So we feel this is what's held that sacrum forward, which has forced the lumbar spine to become hypermobile and basically wobbly, which has laxed the ligaments, which has created the flexion. Now, moreover, and this we can kind of link this up, when you get a really posterior sacrum, so if we're looking at this from the top, just a simple diagram, if that's the sacrum, like so, and then the anonymates, or the big pelvis bones, some people call them hip bones, that's not their name, but that's okay. When you get a really backwards sacrum, so that part goes backwards, that part goes forwards, and these are the various sacral, both ligaments and muscles. It's like a puborectalis. There we go. Bam. So when that's pulled forward, what tends to happen is it pushes out a little bit lateral and pushes the pubic symphysis together. Because this is the attachment point of so many abdominal muscles here and, of course, through here, running up this way. Rectus abdominis, the obliques, the inguinal ligament kind of comes that way as well. This ties it into the abdominal area and then up and through the rib cage. So it makes sense out of some of what we're seeing, because we're feeling this flexion as well. Just to tie it back into the front, this flexion is probably pulling through the abdominals. If they shorten, they'll attach in the pubic symphysis, and they'll assist in pulling it down in this way in a few different directions. There's your external obliques here. External obliques, internal obliques, just get rid of a couple of those for clarity's sake. And this will assist in maintaining this extreme flexion, because they get similar nerves. That pubic symphysis gets nerves that come all the way down from that, T5 to 7 area, all the way down to about as low as T12, L1, as we get closer and closer to the leg. So this makes a fair amount of sense. We can't directly palpate it, but we feel there would be some, increased tension around this area, some shortening and thickening of those tissues. This is what we think. So it kind of brings it around in a nice full circle. So basically, we went all the way from the top. Let me just clear some of this out. We went from the neck, showing that there's some stuck spots and some hypermobilities. We then looked to the way that the upper thorax was dropping into flexion and pulling down, offsetting the center of gravity, changing the way the spine had to be curved. We then looked through into the rib cage, and we saw how we had some folding into the ribs, which brought us back all the way around the back into the T7 area, where we saw both, really lack of side bending, where we saw side bending as well as flexion that was noticed before. So the flexion that was through here, and then from that we were able to find that we had also some pretty extreme flexion in that lumbar area, quite extreme, that made us think that the sacrum was also off. And in addition to that, pelvis, pubic symphysis into the abdominals. So it took us around in a very nice circle. So that being said, a couple notes at the end here. Just want to say we went from the top down. The neck seemed the most significant, and that's based on what we saw as a structural analysis, but as well because that's what the person who contacted us was complaining the most about. One thing we can definitely say is, if something is very acute and painful, doesn't matter what you want to do to the rest of the body, you really have to reduce some of that pain before they will feel comfortable with you moving the rest of the body. That's just one of those basic things you do have to learn. Now, that doesn't mean it was entirely the fault of the neck. The neck is a part of it, but we've got other stuff. Any of these lower problems, especially the lumbar spine, sacrum, pelvis, they do have to be dealt with in their own way. In fact, working from the bottom up is just a reasonable thing to do in many cases. In fact, really, if top down doesn't work, go bottom up. There's nothing wrong with that. If it's severe, it has to be dealt with. So the key point in all of this, and I won't be ever meeting this person more than likely, but the key point is that if we can trace out a cause and effect relationship between a number of parts, they're all reactive to one another. So if we can make the neck relative to the thorax relative all the way down to the ribs and bottom of the ribs, and tie that into the lumbar spine and pelvis, they must be part of a greater whole. All of the areas are involved in the problem, so no one part, no single part of this can be made better without the other parts getting better. This kind of a structural series, all of it needs to be addressed to guarantee a lasting resolution, because they've been there long enough that they will hold each other in the place that they are, in the place out of place. So you have to treat it as a whole. That would probably be the best way of dealing with this. This has been some guy named Elge from Simple Lines Anatomy. Well, I hope that made sense. I had a great time. I will see you later.